Good evening, and welcome to AUA's Innovations in the Surgical Treatment of BPH live virtual course. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so that we are able to continuously improve our programs. The AUA is accredited by the ACCME and designates this live internet activity for a maximum of 1.5 AMA PRA Category 1 credits. Course handouts from the presentations have been made available to you. Please visit AUA University to access the handouts. Evaluations are very important to us. Course evaluations and CME credit will be administered electronically on AUA University immediately following the webinar. As we at the AUA continue to develop virtual education that meets your needs, we especially welcome your feedback regarding both the content and format following this program. All persons in a position to control the content of an AUA educational activity are required to disclose any relevant financial relationships with any commercial interest. Please visit AUA University to view Faculty and Education Council disclosures. The AUA would like to thank Olympus Corporation of the Americas and Teleflex Interventional Urology for providing independent educational grants in support of this webinar. Coding advice given during presentations are the opinion of the presenters and may not have been vetted through the AUA for accuracy. Please verify accuracy prior to reporting on medical claims. Please note that course participants are prohibited from using or uploading content you access through this activity into external applications, bots, software, or websites, including those using artificial intelligence technologies and infrastructure, including deep learning, machine learning, and large language models and generative AI. Finally, I'd like to extend a special thank you to our course director, Dr. Charles Welliver, for his time, talent, and expertise in developing this program. Dr. Charles Welliver is a fellowship-trained expert in men's health. He's the vice chair of clinical affairs and director of men's health at Albany Medical College in Albany, New York. At this time, I will now turn the webinar over to Dr. Welliver.
Good morning, midday, or evening, wherever you're joining us from, and welcome to the AUA's Innovation and Surgical Treatment of BPH live virtual course. The activity goals and learning objectives have already been released out to the group, but this is important as the AUA is launching an educational initiative for those clinicians and other healthcare professionals involved in the treatment of BPH. Here we see the different learning objectives that were previously passed out. I'd like to now take a moment to introduce our excellent faculty for this evening. Dr. Paul Anderson is a consultant urologist at the Royal Melbourne Hospital in Melbourne, Australia. He is the Associate Director of Medical Education at the Royal Melbourne Hospital and an examiner in urology for the Royal Australian College of Surgeons. Paul, it's great to have you with us. Dr. Nicole Miller is a professor of urology at Vanderbilt Health in Nashville, Tennessee. She also serves as the Executive Director of the Endourology Division, the Vice Chair of Academic Affairs, and the Program Director of the Endourology and Minimally Invasive Surgery Fellowship. Nicole was also part of the most recent guidelines, and it's great to have her with us today. Dr. Jaspreet Sandhu is an attending urologist at Memorial Sloan Kettering Cancer Center in New York City, where he directs the Functional and Reconstructive Urology program. He is an Associate Secretary of the American Urologic Association and was Vice Chair of this recently released AUA BPH guidelines. Jaspreet, great to have you. And last but certainly not least is Dr. Nick Warner, who is a reconstructive urologist and specializes in all facets of BPH surgery. He practices at the Mayo Clinic in Rochester, Minnesota. Nick, thank you for joining us. Let's start by exploring the scientific process to create the BPH guidelines and how this process helps determine the results. So first, a bit about the data capture and methodology. For these new 2026 guidelines, the Oregon Health and Science University team searched Medline and Cochrane Library to identify randomized controlled trials and clinically controlled trials published and indexed. The search was then supplemented by reviewing electronic databases and reference lists for relevant articles. For medications, the data capture ran from 2009 to 2025, and for procedures from 2017 to 2025. Criteria for inclusion and exclusion of these different studies and data were based on the key questions in populations, interventions, comparators, outcomes, timing, types of studies and settings, or PCOTS questions of interest as were developed by the guidelines panel. The guideline statements have two different segments about the evidence, and the strength of the evidence is largely based on the certainty of the data. So there's the AOA strength of evidence category A, B, and C, which correlate with the grade certainty of high, moderate, and low. In the high or grade A category, the guideline committee felt that they were very confident the true effect of the therapy lies close to that of the estimated published effect. In the B or moderate category, the true effect is likely close to the estimate of the published effect, but there's a possibility that it is substantially different. In strength C or low, the true effect may be substantially different from the estimated effect. Of course, we need to link these statements to the evidence, and this is based on the level of certainty and the magnitude of difference between the benefits and the risks of that therapy. In a strong or moderate evidence grade, a directive guideline statement is created as there is a demonstrable difference between the benefit or risk for that therapy. A conditional statement would allow for a non-directive guideline statement, or a conditional evidence grade would allow for a non-directive guideline statement, as that risk versus benefit weighing is a bit unclear. A clinical principle is a widely agreed upon concept, but there's no evidence, or the evidence is outside the data capture for this guidelines. An expert opinion is a consensus panel statement based on the training, experience, knowledge, and judgment of the guideline panel. Let's dissect out a few statements to further understand this. So here we have the alpha blocker monotherapy statement. Clinicians should offer one of the following uroselective alpha blockers as a treatment option for patients with LUTS BPH. So this got a strong recommendation as the benefits certainly outweigh the risks. It applies to most patients in most situations, and future research is really unlikely to change the confidence in this at this point. Got an evidence level of grade A as we are very confident in the reported effect and there's a high level of certainty. This compares with guideline statement 27. In patients with moderate to severe predominance towards LUTS, clinicians may offer anticholinergic agents alone or in combination with alpha blockers as a treatment option. This got a evidence level grade C because the confidence in the effect is limited, and the true effect may be much different than the observed or estimated effect, and better evidence may change the confidence. It was a conditional recommendation as there is an unclear balance between the risks and benefits of this treatment option, and alternative strategies may be equally reasonable. The supporting text that goes with the statements is meant to be evidence-based, explanatory, and educational. While the randomized control trials and clinically controlled trials are used to generate the statements and are generally utilized in supportive text, authors may pull in other publications to help illustrate and reinforce important points. So I would make the, again, important point that reading the guideline statements is great, but I also highly recommend that you read the supporting text, as important explanation or caveats may appear in text that somewhat modify the guideline statement above. For instance, in the TERP statement, monopolar TERP was only recommended for glands less than 80 cc's due to risks or concerns about dilutional hyponatremia, and this really only appeared in the text. So while reading the statements is great, please also take a moment and read the text. All right, let's move over into our innovations in surgical treatment of BPH. What is new in these guidelines and how can our new statements be used to influence day-to-day patient care? First up will be Dr. Warner talking a little bit about behavioral modification.
Great. Thank you, Dr. Welliver. Okay, so when we look at the behavioral modifications, what we're really looking at, number one, is health of the weight. So making sure a patient is a good BMI, I think, is really important. We know that obesity has a higher risk of overactive bladder and lower urinary tract symptoms. Salt intake, of course, influences the fluid intake and fluid urine production, so very important. We all know that constipation can also press against the prostate and make it harder, and it's also an underlying physiologic outlet issue if somebody has chronic constipation. So really managing the constipation is super important. Particularly for the nocturia patients, we really want to work on fluid restriction, particularly right before bedtime. Usually we tell our patients 3 hours before bedtime just to make sure that they're a little dehydrated overnight. Good behavioral modifications, even if somebody doesn't have prior prostate surgery, learning how to do a proper Kegel exercise, which we know feeds back to the relaxation factors of the bladder, is a good technique, especially if they have a lot of urgency. And then really, there's no evidence of which of these to go forth with, but kind of shotgun approach in my practice. Try to go through all these and we give them a handout that has all these listed. There have been several randomized controlled trials looking at the lifestyle modification, pelvic floor physical therapy, Tai Chi, weight reduction, and they really do favor these lifestyle modifications. So I think there's, as you can see, grade B evidence that really supports these assessments and these recommendations that we make for our patients.
And then
Okay.
Dr. Anderson will tell us a little bit about the new statements on combination therapy.
Thanks, Dr. Welliver. So I think we're mostly all very familiar with using combination alpha blockers and 5-alpha reductase inhibitors, and there's been strong evidence to support this combination for some time, and that's why we have a level B recommendation. This is because there's been some large randomized studies over many years that have supported the benefit of this combination over single agents. There are some caveats, of course. A 5-alpha reductase inhibitor is only really beneficial in those patients with larger, more glandular prostates, greater than 30 cubic centimeters, or a PSA of greater than 1.5. That's because that's how these medications work, by causing cytoreduction of the glandular elements of the prostate. The new guidelines, however, have some further recommendations. There we go. For some new combinations, as there is emerging evidence for some of these. Not quite as good evidence, only level C in this instance, because they are smaller studies. So adding a PDE5 inhibitor to an alpha blocker seems to have an added benefit. Of course, this is useful for patients who have concomitant erectile dysfunction, but is also effective in patients who do not have erectile dysfunction, so it can be considered for those as well. There's also been studies looking at using a PDE5 inhibitor with a 5-alpha reductase inhibitor, and this may be of advantage for patients who perhaps can't tolerate an alpha blocker, or who have been experiencing side effects from the 5-alpha reductase inhibitor, and this may be mitigated somewhat by the PDE5 inhibitor. And then, of course, we have patients who have predominantly will have a mix of voiding and storage symptoms. These are patients who have frequency and urgency in addition to their obstructive symptoms. And these patients may find a benefit of adding either an anticholinergic or a beta-3 agonist to their alpha blocker. And again, we now have studies showing that this benefit, these combination adds additional benefit and can be used safely and effectively.
As part of the new guidelines, a new procedural algorithm was developed, and Dr. Miller will fill us in on that.
Thank you so much. I'm really excited to be here. So the new procedural algorithm really changes how we use imaging. You can see when the guidelines were originally published in 1994, we actually recommended against imaging. But in the newest guidelines, imaging is key to choosing surgical therapies. And the other thing you'll notice in the algorithm is how many more therapies there are. Particularly with the introduction of a lot of new minimally invasive surgical treatments, particularly with the ability to now preserve ejaculation. The algorithm is now going to address how you might choose procedures based on size as well as ejaculation preservation. So the algorithm is broken down into less than 30 cc's, 30 to 80 cc's, greater than 80 to 150 cc's, and greater than 150 cc's. And actually, we'll just go to the algorithm and I'll be able to show you the color coding. So if we look over here, we're going to start with the assessment of prostate size. You may also consider cystoscopy if you want to be looking for whether there's a median lobe or not, and I'll explain why that's necessary. We then see the categories here of small, average, large, and very large. Of course, this 30 to 80 cc's, I think, is the sweet spot. It's going to be where you're going to have lots of options for patients. When we talk about ejaculatory preservation possible, you're going to see that in this darker blue color. And where ejaculatory preservation may not be as prioritized, it's going to be here in the light green color. Next, I want to turn your attention to these little asterisks and special designations. So particularly for the prostatic urethral lift, the temporary implantable prostatic device, and the intraprostatic drug-coated balloon, there should be absence of a median lobe. And then for the intraprostatic drug coated balloon, also you need to know the prostatic urethral length, which again is designated down here in the algorithm, which should be between 32 and 55 millimeters. We also, in the algorithm, talk about special cases, now addressing primary bladder neck obstruction, where you should consider TUIP, the temporary implantable prostatic device, or TUR of the bladder neck. And then again, which is not unchanged really from the prior guidelines for patients that are at increased bleeding risk, the laser procedures such as laser enucleation with holmium, so HOLUP, THULUP, PVP, and then added here prostatic artery embolization. And then one more comment about PAE is that it should be offered to men who have at least a 50 cc prostate. I think I've covered most of these bullet points in the review of the algorithm. The indications to consider surgery really are unchanged from the prior guideline. Patients with renal insufficiency due to BPH, refractory urinary retention, recurrent urinary tract infections, recurrent bladder stones, which you think are related to BPH, gross hematuria. And for patients that have LUTS and BPH that's refractory to other therapies, or if they don't want to use other therapies. You do not have to fail medical therapy in order to consider surgical therapy for BPH. Again, the procedural indications for patients with a bladder diverticulum are largely unchanged. We do not recommend treatment of an asymptomatic bladder diverticulum. However, in these patients, you may want to consider evaluating them for the presence of bladder outlet obstruction. If you do decide that the bladder diverticulum needs to be treated along with the bladder outlet, then you might consider a technique such as a simple prostatectomy where the diverticulectomy can be addressed. And then as far as follow-up recommendations, there had been recommendations for medication follow-up in the prior guideline, but not as much for surgical therapies. So in this case, we're making the recommendation that patients that undergo surgical treatments for BPH should be assessed for at least 1 year after surgery. You're monitoring for the development of any obstruction from complications such as urethral stricture or bladder neck contracture. And also, particularly with some of these newer minimally invasive surgical treatments, we know that the retreatment rate is going to be higher than for some of the other procedures. And therefore, you want to assess for any symptom return and need for additional therapy.
As we have more and more men now on active surveillance for prostate cancer, we have the opportunity to treat these men for LUTS due to BPH. And Dr. Sandhu will fill us in on the new statements for active surveillance BPH treatment.
Thank you very much, Dr. Welver, for this opportunity. As all of you know, active surveillance for prostate cancer has exploded. Active surveillance is classically used for low-risk prostate cancer in patients in whom we don't think prostate cancer is going to progress. And a lot of these men these days have pretty significant lower urinary tract symptoms. Now, whether that's related to BPH or prostate cancer is pretty clear. It's generally related to BPH, but it's LUTS in men on active surveillance for prostate cancer. And classically, we treat these patients just like men with LUTS due to BPH. So anti-blockers and daily PDE5 inhibitors are still acceptable options. And while there's an FDA black box warning on 5-ARIs that's specific to the not necessarily development, the detection of high-risk prostate cancer in men who are started on 5-ARIs, the FDA, at least in the United States, tells us that when we start men on 5-ARIs, we should talk to them about this consistent increase in the detection of high-risk prostate cancer. Whether or not that's a detection issue or truly a causal issue is unclear, but we do know that in men on active surveillance, this has not been shown to be all that important. So disease progression risk for 5-ARIs has not been established for patients on active surveillance. And providers should be, so there are a few studies that have been done on large populations of patients on active surveillance that have shown that 5-ARIs do not lead to progression of disease. So there's no difference in patients who are on 5-ARIs versus those that are not. And that's probably due to the fact that these patients are followed so closely with imaging. They're followed with imaging, it's unlikely that they're going to have a high-risk prostate cancer that is not present on imaging. So we feel very comfortable in using 5-ARIs in addition to the other medical modalities. Now, you should be cognizant of the fact that if you start a patient on 5-ARIs, PSA dynamics change. So PSA decreases by 50%, and you've got to reestablish a baseline for active surveillance purposes after 6 months of treatment. Now, this is well stated in Guideline 61, which I'll let you read and go on to the next slide. And the next slide basically talks about procedural treatments. So we talked about medical treatments. We also think procedural treatments can generally be given to, or can be offered to patients on active surveillance for prostate cancer and should not be an issue for future cancer therapy. Now, there is one caveat. In patients pursuing radiation therapy, bladder outlet obstruction, reducing procedures should be addressed first, partly because of the risk of urinary incontinence in patients who have radiation therapy followed by one of these procedures. And there's very little data to support that radical prostatectomies and outcomes after radical prostatectomy are any different in men who've had a previous BPH procedure. So those can be, if patients progress in active surveillance, they can choose either one of those therapies. So non-ablative options should have no effect on PSA. That includes TWEEP, or transurethral incision of the prostate, urethral lift, temporarily implantable prostate devices, and intraprostatic drug-coated balloons. Those don't have any effect on PSA. You should be aware that prostate urethral lift has those titanium clips, and those can cause artifact on MRI. Now, while most radiologists have means of accounting for that, it still will actually cause some artifact in those areas. So moderate artifact in 19% of exams and poor image quality in 9% of exams in this study from 2023. So that's stated in our guideline statement, which says PUL should be accounted for with PUL. So ablative therapies will reduce PSA. So it's important to reestablish PSA baseline after these procedures. Different procedures have different degrees of decrease in PSA. So it's important to note that. Patients pursuing ablative therapy may be more likely to discontinue active surveillance protocols. That may or may not be true, but know that used to be the case. And ablative therapies may produce pathologic specimens that may have benefit in evaluating men on active surveillance protocols. Now, that's only important if prostate cancer is in the transition zone. As all of you know, prostate cancer generally is in the peripheral zone, and all these procedures only get tissue from the transition zone. So I tend to look at MRIs, and if I think it's important to get tissue, I offer them therapies which gives good tissue, such as TURPs or open prostatectomies or OLEPs.
Great. Thank you so much to the panel members. Let's move into our next segment, talking about communicating patient expectations regarding treatment and maintaining a patient-centered focus. So with our armamentarium of medication and procedural options, we have a lot of varieties and a lot of little nuances with these options. So it's an important point is defining what means success to your patient. There's a variety of different things that might be important to them, things like the need for BPH treatment or retreatment, preservation of sexual function, or reducing or minimizing peri-procedural complications. So our new statements address many of these, particularly under the general procedural principles. There's some on education assessment of sexual function, some on bladder health and function, and looking at BPH retreatment rates. So first, let's talk about medication sexual side effects. Alpha blockers, these are mostly ejaculatory dysfunction and are very drug specific. Five ARIs, we talked about that increased rate of detection, and that was an excellent point. It's not development, it's detection, and we don't know if there's any causality there. But five ARIs are also very challenging as they cause problems with erectile dysfunction, ejaculatory dysfunction, and also problems with libido. The good news is daily PD5s have maybe the greatest sexual side effect profile of any medication, and that they have better erections. What a great side effect. So, Dr. Sandhu, when you see men for initial BPH treatment options, and you talk about alpha blockers, PD5 inhibitors, how do you decide who to start on what?
Well, I think you just answered the question, right? I mean, there are some men who come in who also complain of erectile dysfunction, in which case, daily low-dose tadalafil is always the right answer. But understand that tadalafil doesn't lead to an improvement in uroflow and so forth. So the only real drugs that lead to increased uroflow or flow rate are alpha blockers. So there are some men who are only bothered by markedly diminished stream, in which case you offer them alpha blocker. In that case, you have to worry about ejaculatory dysfunction. And alpha blockers, while we say in our guidelines you should offer uroselective, all those have different profiles in terms of causality when it comes to ejaculatory dysfunction. If patients are worried about retrograde ejaculation or anejaculation, you should almost always offer them alfuzosin. Now that, of course, assumes that they're cardiovascularly and otherwise fit. But alfuzosin is the one that's got the least amount of ejaculatory dysfunction among the alpha blockers. 5-ARIs, as you know, can cause decreased desire or libido. But what's more important is they do often have ejaculatory dysfunction. So this is something we didn't recognize as much. But they often have decreased semen volume. Erectile dysfunction, obviously, is only with 5-ARIs. So it's important to note all that. The difference in men on who are deciding between PD5s and alpha blockers, that's always a difficult decision. But usually it comes down to whether or not they have initial sexual or erectile dysfunction.
Great. So along those lines, we have some new guideline statements about sexual function. And really, as doctors, one of our most important jobs is to be educators. So there's a guideline statement here talking about erection, orgasm, and ejaculation are all physiologically different, and these can occur independently. Patients may not understand what these different terms mean and how they are and are not related. So an important point with maintaining that patient-centered focus is to figure out their existing dysfunction. Dr. Anderson, how do you talk to your patients and understand their existing dysfunction? Do you use questionnaires? Do you just have an old-fashioned chat?
Well, there's certainly different ways of broaching these issues, and I think it depends a little bit on your practice. I have quite a linguistically and culturally diverse practice, so you really can't make assumptions about how patients understand these things. And some patients are more comfortable about talking about them than others. In my practice, what I like to do is I just sit down and draw a diagram of the lower urinary tract and where the prostate is and how it links up to the testicles and how it relates to the bladder, and actually start talking about the prostate and how its function is producing fluid that it is part of the ejaculate. And I think once you start talking about it on physiological terms, that often is a good way to open up the conversation about what might be going on with their erectile function, what might be happening with their sex lives. And you get a feel for what sort of priority the patient has for these various issues. And then I think when you start to talk about therapies, you can refer to your diagram and explain, why it might affect things like ejaculation and how that all works. So that's how I do it in my practice.
It seems like, demystifying it is really a good thing to do to help patients talk about it. All right, so we also have some new statements about bladder health. Clinicians should counsel patients about progressive bladder functional changes associated with LUTS BPH. Men are living longer and our BPH procedures have just gotten safer and safer. Bladder function or changes are potentially non-recoverable. And there is this theory of move from normal bladder to overactive bladder or storage symptoms, and still with poor treatment or under treatment, areflexia or hypocontractility. There's some bladder hypoxia or damage to the elasticity or contractility due to continued obstruction that starts the cascade. And there's really no specific timeline from normal to problematic. This isn't a weeks to months. This is probably a years to decades idea. But this does still make a case for earlier intervention. When you guys offer definitive treatment to younger men, they're less comorbid. They may get the full benefit, and you can avoid some of those bladder changes. I'll urge you to look at Appendix 3, which looks at the different retreatment rates for all of our different options. We do have 1, 2, 3, and 5-year retreatment rates, but really this is often a longer game. So, Dr. Miller, how do you talk to patients about 10-year retreatment rates or lifetime retreatment rates, particularly with this mix of studies that we have to make this appendix?
Yeah, I mean, I think you have to be very honest when you discuss with patient what the retreatment rates are, because, this being such a dynamic field, there are constantly new procedures being introduced, and you're not going to have 10-year data. But I think there's a reason why we keep talking about TURP many, many years later, right? So we know that the retreatment rate is low for procedures that remove tissue. And the retreatment rates are going to be higher for some of the mists. I think that patients just want to know as much as that you can tell them, and they're going to make a good decision based on the risk-benefit profile. And the retreatment rate is just one of the categories to discuss with them.
Yes, amongst the many. So other side effects, retreatment, BPH, or non-BPH specific, things like stricture and incontinence, sexual dysfunction. And there is some guideline statements looking at how these ejaculatory sparing procedures may increase the risk of BPH specific retreatment, as they do have a tendency to leave more adenoma behind after the procedure. So just to summarize this portion, it's important to define the existing sexual function of the patient, know and understand procedural specific retreatment rates and side effects, use prostate shape and size to inform your decision making, and to really understand the patient goals to find the right treatment option for your patient in this patient-centered approach. Move into the next portion, reviewing pivotal studies of some of our myths that are in this guideline. So the MISC guideline statement recommendations, really, as we said earlier, are based on the randomized control trials and clinically controlled trials that were registered primarily with the FDA. These different treatment options may get further indications in the future with Medicare or the FDA or your country's regulatory body based on these future studies. So you can see here that the similarities between all of these options in the guideline statement sizes, and this is largely related to those initial randomized controlled trials that were registered. So for prostate urethral lift, 30 to 80, no obstructing median lobe, water vapor thermal therapy, 30 to 80, 25 to 75 without an obstructing median lobe for the temporary implantable prostate device, and for the drug-coated balloon, 20 to 80, a known prostate urethral length, and again, no obstructing median lobe. Talking a little bit about water vapor thermal therapy. This is that initial randomized controlled trial with the FDA, 136 men undergoing treatment versus sham, see improvements in IPSS that outpaced sham, and these were fairly durable out to 12 months. There's really minimal sexual dysfunction and no de novo ED, using a variety of different questionnaires to follow the erectile and ejaculatory function over time. They then went on to attempt to expand those indications to get beyond the 30 to 80. And here we see a meta-analysis of 15 different studies over 400 men, all with prostate volumes greater than 80. We still see a good change in IPSS and Qmax. And then a comparison trial, randomized control trial versus TURP, so no longer against sham. 62 minutes versus 8 minutes in the water vapor thermal therapy. IPSS improvements in both, but better in TURP, but also more sexual dysfunction. So this really solidifies water vapor thermal therapy into our missed category here. Quicker procedure, maybe not quite as pronounced improvements in urinary outcomes, but less sexual side effects. Prostate urethral lift, the lift study, again, improvements over sham, durable out for years, really minimal to no sexual dysfunction. We do have the median lobe as an exclusion criteria in these guidelines, but they do have the MedLift study, which looked at treating men with a median lobe, pulled the median lobe across. Dr. Warner, I think you have some experience with this. Any tips or tricks on how to do this effectively?
Yeah, so UroLift, they come with a separate median lobe device, but it does work better, but I don't think it's necessary. And what I like to do when somebody has a median lobe, first of all, it has to be fairly pedunculated. It can't be just a little ridge of a median lobe. It actually has to be on a stalk. And then I choose whichever groove is the deepest, and I put my device into that groove and then into the bladder and almost sweep it backwards as if I was like bringing a finger back across. And what happens is that median lobe will kind of pop into the fossa itself rather than being in the bladder. and then you have a couple practice runs. Usually I'll use my last device that's been fired and practice it a few times, just pulling it into position. And once I get to a position I'm happy, I'll get the new device in, repeat the process, and then anchor it in. And you can see on the diagram here, you don't want to go too posterior with that anchoring. You do still want to keep it in the horizontal plane so that you're not going to fire it into any of the vasculature.
Right. So you're really trying to pull it into the prostate fossa when you're doing that. Okay.
Correct. Yep.
Cool. That's a great tip. All right. When we look at the MedLift study, this is men that had an obstructing median lobe, and when they compared it to the lateral lobe only group that didn't have median lobes, you see very similar outcomes with regards to IPSS. Again, durable over time. Again, trying to expand indications, line size over 80, over 1,400 patients, 10 sites, and had reasonable efficacy still over 80 cc's and even over 100 cc's in a lot of these cases. All right, moving into part 2 of tonight's webinar, we'll look at the different discussion of different various surgical techniques. Dr. Anderson will lead us off talking a little bit about intraprostatic drug-coated balloon.
Thank you. Sorry, I'm just here we go. Just taking a moment with the slide, I apologize. Here we go. Okay, so this is the intraprostatic drug-coated balloon, which is a relatively new, minimally invasive surgical technique. It doesn't involve any cutting, and there's no energy that's used, and there's no permanent implant. One of the advantages of this technique is that if it's done and the patient progresses, it doesn't stop you from having any future surgical procedures. So the principle is there is a balloon that's used to dilate the prostatic fossa, and then a drug is delivered to prevent that dilatation from healing over. This technique is suitable for prostates between 20 and 80 cubic centimeters. And specifically, you need to look at the length of the prostatic urethra. It has to be between 32 and 55 millimeters, and there are different sizes of balloon to accommodate the different sizes of the prostate urethra. It's not effective at treating the median lobe, so it's not suitable for patients that have a prominent median lobe, and it can be done under simple sedation. So here we've got a diagram of how the device works. It's inserted transurethral into the prostatic fossa. It has a bilobe balloon. So there is the distal part of the balloon, which is inflated to hold it in position at the bladder neck. And then the proximal part of the balloon is the part that dilates the prostatic fossa. What it does is it actually causes a split in the anterior commissure of the fossa, or so-called commissurotomy. And then after the commissurotomy is done, a second balloon is placed, and this is coated in paclitaxel, and it introduces paclitaxel into the prostatic fossa to prevent that commissurotomy from healing over. The procedure itself is quite quick. The results are pretty much straight away, and it preserves both ejaculatory and erectile function. You do need a post-procedure catheter for a few days. And of course, paclitaxel is a cytotoxic drug, so various precautions need to be taken in the post-operative period. You need to dispose of the device appropriately, and it's recommended that avoiding sexual intercourse or using barrier contraception for 30 days after the procedure, just in case the paclitaxel is transferred to the patient's partner. Paclitaxel itself has been around for a long time, been used since 1993, mainly as a cytotherapeutic drug for a variety of cancers. But after that, it has been used in both coronary and vascular stents to prevent restenosis, and this principle has been applied in urology in this instance. So again, here we have a diagram of the balloon, and you can see the bilobar balloon with the distal part that is used to anchor it into the position in the bladder, and then the other part of the balloon that goes into the prostate fossa that causes dilatation. There are various sizes, 30, 35, 40, and 45 millimeters. And again, you need to rely on imaging to help you determine which balloon to select. There have been 2 trials looking at this, the initial open label phase 1 style called Everest, and then a randomized trial with the device versus sham called Pinnacle. So the Everest study showed improvement in both IPSS and flow rates at 1 year, and then followed them out for 2 years where the benefit was sustained, IPSS going from 22 points down to 8, and the BPH 2, which is another type of symptom score, also showed improvement from almost 7 to 2. And this was followed up by the randomized study called Pinnacle, 100 patients receiving the inflatable balloon device versus 48 sham. And again, this showed sustained improvement at 2 years in both symptom scores and flow rates. Also, this study showed that there was no change in ejaculatory function, both or erectile quality. They specifically looked at semen volume and semen analysis and showed that there was no impact on these. So this is an impact, potentially an issue for those patients who wish to maintain their fertility. So here we have a video just showing how the device works. So start off by doing a cystoscopy to evaluate the patient and to verify the anatomy. Then the telescope is withdrawn. You notice the finger has been put in over the sheath to maintain a full bladder for the next part of the procedure. So this is the balloon itself. There's a protective sheath that's just being withdrawn. There is a atraumatic tip, which is then inserted down the sheath into the bladder. We then withdraw the sheath and reassemble the cystoscope. So you can then pass the cystoscope coaxially in front of the sheath, or sorry, in front of the balloon, and you move up the cystoscope to identify the external sphincter. You can then adjust the position of the balloon to ensure that the proximal part of the balloon is inside the bladder neck. And there's actually a little blue marker on the balloon device that should be moved to just 1 centimeter beyond the external sphincter. So once you're happy with the position of the device, you can attach the inflation syringe, and this is first inflated to 2 atmospheres pressure, and this should secure the balloon in place. And you can see them doing here what's called the wiggle test. So you just move the balloon back and forth to ensure that it's in the correct position, and you'll know it's in the right spot because everything will move with the balloon. The prostate will move with the balloon. Once you're happy it's in the right position, you then inflate the balloon up to 4 atmospheres of pressure, and this is what will cause the commissurotomy, the anterior commissurotomy, which is the dilating part of the procedure. Sometimes the pressure comes down a little bit as the split occurs. You don't need to increase the pressure, just maintain it at that initial inflation. And you keep this in place for 1 minute. So once that's done, you deflate the balloon and put the cystoscope in again, and then you look at the prostate to confirm that the commissurotomy has been done. You withdraw the balloon, and here you can see the commissurotomy. Now, sometimes you might need to reinflate the balloon once or twice more in order to do that. The recommendation is after 3 inflations, there is no obvious commissurotomy. You still proceed to the second part, which is the paclitaxel treatment. But here in this instance, you can see the commissurotomy has occurred. So now we get the second balloon. This is the paclitaxel coated balloon. It's very important not to touch the paclitaxel or to wash it off or put any sort of fluid on it. If you do need some lubricant, you can put it at the very tip of the catheter to help it be inserted. And this is then introduced in a similar fashion using the cystoscope sheath is inserted, and then the balloon inflated, both to secure it in place and to deploy the paclitaxel into the prostatic fossa. And again, the balloon is inflated to, in this instance, 2 atmospheres, and the wiggle test done to ensure it's in the correct position. Then once that you're happy it's in the right position, increasing the pressure to 4 atmospheres to allow the paclitaxel to be deployed into the prostatic fossa. This balloon is inflated for 10 minutes, and while you're waiting for it, you can prepare the post-operative catheter. In this instance, a 22 French 3-way catheter is being used. There may be a little bit of bleeding post-operatively, so it's important to have the catheter ready to go for when the treatment balloon is removed. So after 10 minutes, the treatment balloon is removed. You can see there's a little bit of bleeding in there. So then the post-operative catheter is inserted with 30 mils into the balloon. It's often helpful to put a bit of catheter traction at this point. You can also use bladder irrigation if necessary. And you can see here, with a little bit of catheter traction, the return has become clear. And that's the end of the procedure video.
All right, very good. So, Paul, what are some of the important points during workup and counseling, particularly as you sort of assess men for this minimally invasive technique or minimally invasive techniques in general?
Well, it's no different to any other procedure. You need to make sure the patient has the right diagnosis. So history, examination, you want to check their flow and their residual volume. It's probably helpful to do a cystoscopy or at least get to some ultrasound imaging to make sure that there's no median low, because this is not particularly good technique for that. And then, of course, you need to make an assessment of the prostatic length, because this treatment is limited to that range of lengths, 32 to 55 millimeters, because that is the size of the balloon. This is a good technique for avoiding ejaculatory dysfunction. So again, there may be some patients who wish to preserve their fertility in particular. That may be a reason to do this over others. And again, it's a fairly simple, straightforward procedure which may make it of interest to the surgeon.
All right, so you talked about much of this. Can you tell us a little bit about some of the contraindications for
Yes.
this?
So these are largely based on the selection criteria for the trials that we described before. So you don't want to do it in patients who've got active infection or have concomitant cancers, because this is a cytotoxic agent and it's not really been demonstrated. We don't really know how it impacts on their cancer treatment. And it's not good for people with high residual volume or neurogenic bladder. While a similar device is used for urethral stricture, we don't recommend that this is used for patients who have a stricture as well as the other stricture treatments.
It's a good point. Oplume does have a stricture treatment, but it's a different balloon, different size. Still paclitaxel, though.
Indeed.
All right. Question number 3. Can you tell us more about the clinical data and what has been published since those initial FDA trials?
Yeah, so there was an analysis done of the patients in this trial, and it seems to be that there's actually 2 different groups: those patients who respond and those who seem to be non-responders. And the theory is that there are a group of patients where the commissurotomy doesn't really occur. The prostate doesn't really split in the way that you've decided. So you'll have patients that have a good response and then some that have a minimal response. It's probably worth identifying those men, because they might be suitable for another treatment which you could then apply earlier rather than maybe waiting.
All right. Very good. All right, thank you so much. We'll move on to our next treatment, the evergreen of urology, the transurethral resection of the prostate. And Dr. Sandhu will lead us through this.
Well, thank you very much for giving me this. TURP has existed in urology for decades. It was initially filled a gap between watchful waiting and simple prostatectomy, and has been a watchful waiting for lower urinary tract symptoms and simple prostatectomy for lower urinary tract symptoms. And since early days, there's been improvement in electrodes, improvement in optics, improvement in techniques. And despite all these new technologies that Dr. Miller talked about, TURP remains an excellent treatment option for a range of men. So TURP patients, as you can see on the algorithm over to the right, there is TURPs are useful for either men with small prostates, less than 30, or anywhere from 30 to 80 milliliter prostates. Now, there are urologists who will do TURPs on men with larger prostates, and classically, those if you're really well versed at resecting prostate, absolutely go ahead and do it. But generally, patient selection for TURPs consists of obviously a history and a PVR. Uroflow is plus minus, and generally a symptom score. So the IPSS is a very good symptom score. It's got a bother questionnaire question, which is actually probably the most important. So if patients are bothered by their symptoms, we typically offer them a TURP. There is a PSA may or may not make a difference. Prostate size absolutely does. So patients with very large prostates, by that I mean greater than 80 or 100 or 150, you typically do not want to offer a TURP to. So there's no specific prostate volume cutoff, but particularly for bipolar TURPs. But for monopolar TURPs, at least in our guidelines, we recommend staying below 80 cc's or 80 milliliters in terms of prostate volume. So as all of you know, I'm sure, the TURP technique consists of an electrified loop that's used via a transurethral approach to remove essentially prostate tissue. And generally, the tissue you have access to is the transition zone. This was first performed in the United States in the 1920s. And back then, there was no flow rate, there was no continuous flow for sure, and there was no very poor optics. Generally, it was lamps behind the scope. So monopolar TURP was the initial resection that required hypotonic saline or hypotonic solution, which is generally glycine or sorbitol, or occasionally water. But there's a risk for dilutional hyponatremia when you use hypotonic solutions, and that's one of the things that monopolar TURP that was a downside to monopolar TURP. But realize that you get dilutional hyponatremia only when you get hypotonic solution into the bloodstream. So if you control bleeding, the risk of dilutional hyponatremia is quite low. In fact, one of the larger series ever published by Winston Mebust showed roughly, I think, a 2% rate of dilutional hyponatremia. Subsequently, those, certainly my mentors used to do TURPs using monopolar and very large prostates. And I remember having maybe one patient that I recall that had dilutional hyponatremia. But because of that, bipolar TURP was brought onto urologic lexicon. And generally, the reason for bipolar TURP, it is very similar to resection with monopolar. It may not be quite as fast, but it does allow for use in normal saline. And that's because the active and the return electrode are in very close proximity. So you don't have to go all the way to a grounding pad like you would with hypotonic saline. There's certainly advances in optics, which allow for the use of video towers and systems. I don't know how many of you remember holding the scope to your eye. I don't know any residents that currently have ever trained on that. I know some folks internationally have, but generally video systems are a standard of care these days for monopolar or bipolar TURPs. So the technique. So when you do a TURP, this is it should be pretty standard. I know some trainees do not know how to do this very well anymore, but a TURP generally starts with a cystoscope. So you start with a cystoscope, you inspect the bladder, and identify the orifices, make sure they're not too close to the bladder neck, which is where you generally start your resection, and you document that there's no other bladder pathology. If there's a median lobe, particularly if there's an intravesical component of the median lobe, you typically resect that first. And once you resect that, you can generally resect, and I tend to resect the posterior or the median lobe part all the way from bladder neck to verumontanum. There are techniques that start with the anterior aspect, and that's fine, depending on how you choose to do it. I was trained in doing the median lobe and the posterior aspect first, so that's how I've always done it. But once you resect that, you can resect generally from proximal to distal. So resect 2-capsule bladder neck montanum, and we generally obtain hemostasis. I tend to obtain hemostasis as we go. Now, if I do a monopolar TURP, which I think is cleaner, if you do a monopolar TURP, you can actually see the bleeders very nicely, and you can coagulate them very nicely. It's a little different with bipolar in that you have to coagulate around the bleeding vessel. But you can do it as you go, or you can resect a capsule and obtain hemostasis at the capsule, both of which are perfectly acceptable. One of the reasons I like to do it as I go is you get less bleeding, and especially if you use monopolar TURP, you get essentially very low risks of delusional hyponatremia. So once you have resected, you widen the channel, you complete the resection circumferentially by, like I said, first resecting. I resect the posterior first, then one lateral lobe completely, and then the next lateral lobe. And the rationale behind that is if you finish one lateral lobe and you get into trouble, which is rare, if you get in trouble, you can irrigate out the prostate chips and stop. So that's essentially a hemi-TURP, and patients tend to do quite well. So once you've done the complete resection, so in a regular TURP, you resect the posterior, and I do typically the left lateral lobe, the right lateral lobe, anterior and apical tissues. Once all that is done, you irrigate all the chips using either an iliac evacuator or anything else, or a TUMI, and then you place a catheter. And generally, or most people will place a 3-way catheter just to control bleeding. And you can either send patients home. I tend to keep patients overnight. And usually by the next morning, if you've had reasonable hemostasis, patients are ready to go home. Now, the pros of a TURP, it is durable and it's time tested. It's been around, like I said, since the 1920s. There's no prostate shape that you can't do. There are some size restrictions. You do obtain pathology, which may or may not make a difference. So this is not generally pathology for prostate cancer. It does make a difference. So we have a lot of men with low non-muscle invasive bladder cancer, for example, in whom I prefer a TURP. And the rationale behind that is we've had a few men who've had bladder cancer in the stroma of the prostate. That makes them T4 bladder cancer. They might actually need their bladder out. So it's important. In some patients, it's actually important to do a TURP. Now, the other group that I like to do a TURP on is post-radiation. Now, we talked earlier about not doing TURPs in post-radiation patients, but there are some patients post-prostate radiation who have very severe symptoms or obstructive symptoms or have urinary retention that are willing to take the risk of urinary incontinence. In that case, we offer them a TURP. And in that case, I typically do a bipolar TURP in that setting because it doesn't go as deep. But you can also do monopolar TURPs. So those cases, we don't typically do laser procedures. The cons of a TURP, there is some bleeding risk. So you have to leave a catheter in for a day or sometimes longer. Ejaculatory dysfunction is expected, not just common. I tell my patients there's a 70 or so % chance of having no ejaculate. It typically doesn't affect erectile dysfunction, but does affect ejaculatory dysfunction. And you require anesthesia. So it's either general anesthesia or spinal. You don't need paralysis, but you do need anesthesia or general anesthesia. So outcomes, there's a large body of evidence. Typically, there's an increase in Qmax or maximum flow rate from 125 to 175%, and a reduction in symptom score of about 75%, classically in a lot of patients. Now, retreatment is difficult to gauge these days simply because most of these outcomes these days come from the placebo arms or the comparator arms comparing to other techniques. So our guidelines have an appendix which talks about complications, but understand this is generally from comparator arms, and it's probably higher than in patients who undergo a TURP by folks who are specialized in doing TURPs. So if you do a lot of TURPs, your incontinence rate is certainly 1% or lower. Retention rate, unless you're already in retention, is actually fairly low. Bleeding can absolutely happen. Bladder neck contractures on the order of 1 to 2%. And similar strictures, probably on the order of 1 to 2%. So in summary, it's time tested. It's ubiquitously available. Can be done for any prostate shape or size, especially not necessarily size. And generally, it's a comparator for new technologies. So Rarely, if ever, does a new technology have a lower BPH specific retreatment rate than a TURP. So with that, this is a video. Now, this isn't a classic TURP video. This is a TURP, and you see a lot of bleeding there. This is a TURP after aqua. So generally, these days, at least in the United States, TURPs are much more often done in patients who've already had an aquablation, robotic water jet thermotherapy. When you undergo robotic water jet thermotherapy, you don't control the bleeding when the water jets are on. So you have to, after doing the water jet, you have to put a scope in, and you have to control the bleeding, usually with a TURP. Now, you also do a resection. So this is where this comes in. This is a bipolar resection, as you can tell. So there's two colors. And so there's usually a return electrode and an active electrode. And bipolar generally looks different from a monopolar. So the loops are generally thicker, and you can see the plasma corona being formed when you put your foot on the pedal. Now, this looks to me, see that corona? That's classic of bipolar. Now, bipolar, the advantage of bipolar is it controls the bleeding. It actually does a resection really nicely without delusional hyponatremia. One of the disadvantages, and this looks like it's Dr. Warner doing this, which he'll talk about the bipolar enucleation in a few minutes. But one of the disadvantages is that hemostasis is actually not ideal. You have to essentially coagulate around or and not specifically at the bleeding vessel. So if you were to do a monopolar, see that bleeder right there? Generally, what you do if you had a monopolar is you would just put your loop on that bleeder and hit the coagulation pedal and stops it. With a bipolar, you have to put your foot on the coagulation pedal, and you have to work around. So you have to essentially rub around the area to control the bleeding. It's a little harder, but if you get used to it, it's actually very easy. So this, you can tell that whoever is doing this, and this is not my procedure, I can tell with two reasons. One, it's got continuous flow. I tend to use a non-continuous flow scope still, and I tend to use monopolar. So a lot of people call me old school, but that's what I think works best in my hands, and that's what I do. But one of the things our guideline says, is a TURP can be offered either as a monopolar or a bipolar, depending on what the clinician is most comfortable with. So it doesn't specifically say one is better than the other. And so that right there, you can see that you can actually force some of that adenoma forward and then do the resection like this is happening, or you can just do a regular garden variety resection. And like I said, you can resect anywhere. So bladder neck to verumontanum, you resect, and you make a wide open channel. Now this is resecting the base, likely the median lobe, and you get down to capsular fibers, which is the bladder neck, and you control the bleeding. It's actually a relatively straightforward case. I'm sure everybody on the webinar has done a TURP, or at least has seen a TURP. And it's certainly one of those techniques which should be in your armamentarium, if for no other reason. This is the median lobe. So resecting the median lobe can be very, very easy and very, very fast. Once you do the median lobe, you just make a channel and you're pretty much done. It's actually an excellent technique for pretty much any kind of resection. And like I said, it's been around for over 100 years now. So it's extremely important to note and know how to do it, simply because if you know how to do it, you can actually take care of pretty much all or most prostates. And I'll turn it over to you, Chuck, if you've got any questions.
Great. You talked about a lot of the important points during workup and counseling, but do you change anything for guys that are in retention, have a catheter in?
So I do counsel them a little differently. So patients who come in with a catheter who do not want to self-catheterize, I tell them, well, the only real solution is a TURP or any procedure like a TURP. It could be a hold-up, could be a PVP. But I also tell them their risk of retention is probably higher after procedure than those men that did not come in retention. Now, if you're really concerned about it, and we do have some statements about further testing, you can do urodynamics and determine whether or not the bladder is functioning or not. But I tend not to do that simply because whether or not the bladder is functioning or not, the only real treatment is a debulking treatment for patients in retention. And if you do a resective technology or like a TURP, then if you're going to get them out of retention, you will. If you don't, then they're catheter dependent. And even in patients who've got essentially a contractile bladder, you can get roughly 70% of those men out of retention by doing this. Now, the risk is after you do a TURP, I tend to remove the catheter on day one. Men in retention preoperatively often go into retention when I do a void trial that first day. So I replace the catheter, have them come back in a week later, and almost always they tend to void just fine a week later.
In cardiology wants everybody on anticoagulants, antiplatelet medications. In men that really can't stop these, do you still offer TURP or do you change technologies?
So, as Dr. Miller said, I mean, there's better technologies for patients on anticoagulation, antiplatelet medications, but there are some men in whom you only can do a TURP. So post-radiation, for example, I tend to do a TURP. Now, luckily, those patients tend to bleed very little. So patients after radiation tend to bleed very little. And in men in whom you're trying to get tissue, so you look at MRIs, you see a clearly abnormal MRI, and you want to get tissue, you might have to offer TURP in those patients. And if you do, then clearly I would, and in conjunction with the cardiologist, stop the anticoagulation for a few days, generally, 5 to 7 days, and leave them off anticoagulation for another 3 to 4 days, or at least until they're clear.
Right. How might you change your technique based on previous treatments, particularly if the patient has failed a mist, a urolift, or a Zoom, or their preferences or prostate factors?
So, yeah, I mean, median lobe is obviously very easy to get with a TURP. You can hook the median lobe and get it. You can preserve the ureteral orifices far away. After a urolift, a prostate urethral lift, you can actually do a very nice TURP and cut into the suture. So you actually get those inner tines pretty easily. Beyond that, it's all patient preference, right? Some patients are really concerned about retrograde ejaculation. If they're concerned about retrograde ejaculation, unless you've got a technical modification for a TURP that you feel comfortable with, I do not offer those men TURPs. I tell them, there's a high enough risk of retrograde ejaculation that we'd offer you different techniques. And if I were to do a formal TURP, which I tend to do on everybody that I do a TURP on, then our retrograde ejaculation rates are on the order of 70%.
Right. You've mentioned using TURP for guys in radiation or had radiation. Do you change your technique at all for those men?
No, there are two areas that I'm cautious. One is anterior, one is posterior. And the rationale behind that is fistula. So fistula formation only happens in patients, or generally only happens in patients who have radiation therapy and who undergo an endoscopic manipulation. And posteriorly, you run the risk of rectourethral fistula, which is a nightmare. You end up with two bags essentially. Or anteriorly, you could end up with pubic bone osteomyelitis or pubovesical fistula. And if that happens, that's also a nightmare. Typically, in radiated patients, we end up doing a cystectomy diversion of those men.
Yeah, particularly bad outcomes.
Yeah.
All right. So what do we know about procedural longevity for TURP, especially versus other technologies?
So this has been changing, as you know. People are getting worse at doing TURPs. So the longevity, particularly in the comparative trials, is probably not as good as it used to be. I know years ago when I trained people, and it's like walking uphill both ways, but people were very good at doing TURPs. And in those settings, I rarely saw a recurrence. But now, I mean, I like to state it's probably related to the size of the prostate. The bigger the prostate, the higher your risk of recurrence. On an 80-gram prostate, at 10 years, roughly a 15 to 20% chance of recurrence. It is time dependent because prostates continue to grow. But that's a reasonable rule of thumb that I use.
Let's say you inherit a patient, they had a TURP somewhere else, they're failing. How do you work this patient up?
Well, you do a cystoscope first. So, you want to rule out a bladder neck contracture, you want to rule out urethral strictures. But in some of these men, I also do urodynamics. But if you see obvious regrowth of tissue, which you usually do, and it's usually one side of one lobe or the other, then you can offer them a reTURP. A reTURP works really well. And in patients who have failed a TURP or have had regrowth of tissue, years down the road, you just offer them another TURP.
I agree. I think this is the patient population where cyst was like first.
Yep.
Previous BPH procedure failure.
Agreed.
All right, great. Let's move on. Thank you very much, Jaspreet. Let's move on to our next technology. Next up will be Dr. Miller, who will talk to us about temporary implantable prostate device.
Thank you. If you could start my video, it's not allowing me to do so. Thank you. I appreciate it. So I think about the temporary implantable prostate device. That is quite a mouthful. So you're going to hear me refer to it as iTind. But I think of it really as the quintessential mist. It's like an off-the-shelf choice for patients that have BPH and certain criteria. As you can see in the picture here, it's composed of 3 nitinol struts that will sit at the 5, 7, and 12 o'clock position. And then there is an anchoring leaflet, which we'll show you in the video, but that's going to sit right in front of the verumontanum. This is a temporary implant. It's meant to be in between 5 and 7 days. And it's, I think of it as kind of what we have been doing for years with a TUIP, but it provides rapid relief once the device is removed and preserves sexual function. Let's see. My slides are not going forward. Sorry. Would you be able to advance the slide, please? The iTind is intended for patients with 25 to 75 cc prostates. It's important to be sure that the patient does not have a median lobe. And when I think about the ideal patient, it's the one that has the high bladder neck or where you think the bladder neck is part of the obstruction. This can be done under local anesthesia or with sedation. You could advance, please. The other thing I was saying is that, sometimes it's difficult to identify patients with primary bladder neck obstruction. So they may not have BPH. They have just bladder neck obstruction. And this is very common in young men. 18 to 50 years of age, you will see a percentage rate of 28 to 54%. And I often can diagnose this on office cystoscopy, but ideally, video urodynamics is ideal for identifying. And we've used guideline statement 56 to address primary bladder neck obstruction, iTind being an excellent choice for these patients. Next slide, please. In terms of the procedure, we're going to show it to you in the video, but it can be done with rigid or flexible cystoscope. The implant's deployed into the bladder, and then you use this anchoring leaflet, which is carefully withdrawn back into the prostate, will sit right in front of the verumontanum, and that is going to put the struts in the 5, 7, and 12 o'clock position. Next slide. These struts are essentially creating a pressure necrosis at the bladder neck. And over that 5 to 7 days, you're getting essentially grooves within the prostate, which are then going to open the bladder neck and the prostate. Next slide. Here are before and after pictures. Again, you can see these very nice grooves that are in the bladder neck itself. Next slide. Again, additional pictures. Same kind of concept. And again, next slide, please. So common side effects with the implant in place, not surprisingly perhaps, dysuria, some pelvic or perineal discomfort, some hematuria, and urgency of urination. In terms of how we counsel patients, to tell them they should minimize bladder stimulants such as caffeine and alcohol. You really want to limit exercise and activity, sit on soft chairs or pillows, and avoid any hard surfaces. As far as medications, often a Medrol dose pack is given 24 hours before the procedure, and then post-procedure pain medication such as ibuprofen, pyridium. Sometimes beta-3 agonists are also utilized for bladder spasms. Next slide. what evidence is available? Well, the initial study was comparing the temporary implantable prostate device, or iTind, versus sham. This was 16 sites enrolling 185 men in essentially a 2-to-1 fashion. The primary endpoint was the percentage of men that were achieving at least a 3-point improvement in IPSS at 3 months. Next slide. When you compared the iTind to the sham group, 79% of the iTind versus only 60% in the sham reached this primary endpoint of a 3-point improvement. And actually, when you looked at the mean change in IPSS, it was 9 for the iTind versus only 6.6 in the sham, and this was statistically significant. When we talk about the responder analysis, meaning patients that had at least a 7-point improvement in IPSS at 12 months, again, this favored the iTind group at 72.6% versus only 50% in the sham. Next slide. There are really no change in erectile dysfunction, so that's not a concern with this procedure, and very few significant adverse events. This is pretty well tolerated by patients. Next slide. All right, so we're going to show you the video here. The videos are playing side by side. In this first video, you'll see the cystoscopic view, again, kind of high bladder neck. The scope is put into the bladder, and then the inner portion of the scope, if you look at the this video with the hands, you'll see the inner portion of the scope is removed, and then the iTind device is loaded through the outer sheath of the cystoscope into the bladder. This is not dissimilar to what we were seeing with the balloon inflation device. Once the iTind is in the bladder, then the scope is going to be passed next to the device. As far as preparation for this procedure, often a periprostatic block is performed, and they're often, some patients will prefer sedation, but you can do it with just a block in the office. You'll see that this surgeon is using a 17 French rigid scope, but you could use a rigid scope or a flexible scope. When you reinsert the cystoscope next to the device, you'll see that blue line on the top of the device that orients the device. It should be at the 12 o'clock position. Now we're looking at the device in the bladder. You can see the anchoring leaflet. Now this is going to be pulled into place. If you look at the hands, you can see pulling the device into place, which brings the anchoring leaflet back into the prostatic fossa. It's going to kind of almost rake over the bladder neck. And then it's going to sit right in front of the vera montana. That tells you that your anchoring leaflet is in place and your struts are properly in place. Once the device is in place and you're comfortable with the way it looks, then the cystoscope will be withdrawn. The device has a small suture that is attached to it. You can tape that or secure it to the outside of the body until you're ready to take it out. Next slide, please. So this is a video showing the removal. So you want to take a snare, place it through a catheter, and you're going to grab the suture tether. Put that through the snare, which will then help you pull the suture tether back through the catheter itself. Once the suture tether is back through the catheter, you're going to push the catheter forward, essentially to the level at which the device is deployed. I'll let the video catch up here. So here we're pushing the catheter forward. You need to keep the suture pretty taut. Push the catheter forward until you feel some resistance at the level of the device. And it's at that point, we don't want the patient to help. So your assistant's going to hold his hand. And then you're going to pull pretty firmly on the suture. What that's going to do is it's going to fold the device like an umbrella closing, and then you withdraw a catheter in the device as one unit. Next slide, please. Okay.
All right, great. Thanks for taking us through those videos. How do you work up patients for MIS? What is an important point of counseling for MIS in general and this option in particular?
Yeah, I mean, I think that we've talked about this many times in this webinar so far, but the mists are really ideal for the patients who are really interested in preserving their ejaculatory function. When we're thinking about this procedure in particular, you really need to be certain that you have a prostate size that's appropriate. So for this, 25 to 75 cc's, and you really cannot have a median lobe. And again, we talked about identifying the ideal patient, which in my mind is the one that has a bladder neck component. I would say the vast majority of patients with smaller prostates that have obstruction have some type of obstruction at the level of the bladder neck where this would be an option.
Yeah, I agree. I think it's when it's not size, you really have to kind of worry about shape as a guy that's symptomatic. Get my next question here. Can you tell us a little about the guidelines, indications, and some of the contraindications for this option?
Yeah, so I guess I mentioned already that the size of 25 to 75 cc's and no median lobe. But the contraindications are super important too. Patients cannot have a nickel allergy. Obviously, we do not want to put this into anybody who has an active urinary tract infection or has any prostatitis. If they've had an artificial sphincter or have a history of prostate or bladder cancer. And this is not the procedure that you would use for somebody who has bladder hypocontractility, chronic retention, neurogenic bladder, atonic bladder. It's really not going to be, you're not going to have the results that you want. And then, you're instrumenting the urethra and you need to be able to put the device in and take it out. So it's really not well used for someone who has any type of urethral stricture or really, I would say, bladder neck contracture either.
Great. So you talked about a lot of those initial FDA trials. Can you tell us a little bit about this prospective multi-center study?
Yeah, so initially 81 patients were enrolled. There are 50 that were still available for follow-up at 3 years, and 41 patients of those 50 had over 4 years of follow-up. So we're seeing sustainable improvement in IPSS at greater than 4 years, and with an improvement in IPSS of 45% over their baseline values. And really, retreatment was only necessary in 2 patients of the 50 at 3 years.
Great. So people may be a little surprised about 40 patients at 4 years, but that's pretty standard for a prospective study, 30 to 50% of patients still
Yes.
being able to be followed 4 years out. So great. Thank you so much. Great. That was great. All right. And can you tell us a little bit more about how this compares to some of our other minimally invasive options?
Yeah, and I think that's the hardest question, right? Like, which one do I choose? I think if you look just at the different parameters, you're going to see a IPSS change that's very similar, improvement similar to Resume, better than Urolift. You're going to see flow rates that are better than both of the other procedures, Urolift and Resume. PVR, I think, is going to be pretty, I don't know, that I don't take a lot of stock in those changes in PVR. Is that clinically significant? I mean, yes, I-10 here shows a greater PVR improvement, but I wouldn't say that that's clinically significant in those numbers. But I think it is important to look at the retreatment rate. It's going to fall somewhere between Resume and Urolift at 8.6%. I think what's really nice about this procedure, though, is that you don't have to put a catheter in afterwards. Patients really don't want a catheter in, versus the patients that are getting Resume, who are getting catheters 90% of the time, and often they're staying in for quite some time. So I think it's really an ideal off-the-shelf quintessential mist.
All right, great. Yeah, no energy source needed at all. So a true mist, as some might say.
True mist.
All right. And to round out our night, and this obviously wasn't meant to be exhaustive of all the different options, but we do have a discussion here of transurethral bipolar nucleation, which will be led by Dr. Warner.
All right, thanks again, Dr. Welher. Let me get my video on. Yeah. Okay, so we're going to talk about transurethral bipolar enucleation. And I like to say this is sort of the gateway to enucleations because I think the techniques are pretty similar. I was initially changed to HOLEP. I was trained in HOLEP and switched over to bipolar enucleation. The reasons I switched, one was the morcellator. You can do a bipolar enucleation. Once you get it mostly enucleated, then you can resect the tissue rather than requiring a morcellator. Also, the fact that the bipolar technology essentially is in every hospital I visited across the world, and if I've done this in over 10 countries, and probably over 15 different hospitals in my career. I will emphasize that there is still a significant learning curve. And I think more than anything else we've seen tonight, the learning curve for enucleation surgeries, I think without argument, is one of the harder BPH procedures to learn. You can see here where it falls into the category. Essentially, for any size prostate, you can offer the anatomic enucleation of the prostate. And AAEP, I think, includes HOLEP, BiPolep, THULEP, and I would argue simple prostatectomy is a form of enucleation just done from above for bigger prostates. But essentially, all size prostates, it's a good option. Here it's not recommended for the smaller prostates, but honestly can still be done in that population as well. For the workup, we really depend on IPSSS, Uroflow, PVR, and prostate sizing. I think mostly from the prostate size, we like to know that just so we don't get surprised by the amount of time it takes us to do the operation. For sure, we tell our patients expect the ejaculation to be lost after these operations. So if somebody is ejaculocentric, is a term my colleague Dr. Kohler uses, then we are not going to be offering the enucleation procedures, and we'll recommend maybe the water jet or something along those lines. To perform the enucleation surgeries, I think there's several different approaches. The one I'm going to show a video of is a median lobe only, where we're going to create grooves kind of at the 5 and 7 o'clock, and that's a great starting point. In the aquablation video you saw, I kind of created a 6 o'clock groove, get down to the capsule. You can also do what's called an en bloc procedure, where you start distally at the level of the viru and do a circumferential incision of the mucosa at the level of the viru, and then get to the plane of the prostate and bluntly develop that plane as you work back toward the bladder neck. Either approach, if you're going to not have a morcellator, you want to leave it attached so you're not chasing these large tips around, and then you can resect it into small pieces as you go. Different electrodes have been developed for this procedure, and I think any of them work fine. My preference is the one you're going to see, which is the plasma band, and I like this one because you can push fairly aggressively with this one. Also, it has a large surface area for the coagulation, similar to what a button might offer. But I've done this with a button, traditional loops. They all work pretty well. And then in theory, enucleation is enucleation, meaning that whether you're doing bipolar enucleation, dual luminal laser enucleation, or HOLEP, really, I think your outcomes are going to be pretty darn similar. And there's been several randomized controlled trials that have shown that. So here's just some evidence. This was a study looking at bipolar TERP, vapor, BiPolep, and open simple, and this was for prostates over 80 grams. And bipolar and open simple were really or BiPolep and open simple were the highest surgical efficiency, and that means how much tissue you got out for the time of the operation. However, open simple, of course, had a higher bleeding risk with a 7.5% transfusion risk. And in this study, the BiPolep transfusion rates were roughly 1%. Importantly, similar outcomes with IPSS, QMAX, and PVR. Another randomized control trial looking at HOLEP, mean volume was 130. The HOLEP population demonstrated a shorter catheterization time and hospital stay. However, similar outcomes in the IPSS quality of life without significant differences in the PVR or QMAX, and really no other difference in adverse events. In addition to the retrograde ejaculation, I think the other risk factors would be urethral stricture rates, which on average hover around 2%, and bladder neck contracture, which is really dependent on prostate size, but smaller prostates have a higher risk of bladder neck contracture. Larger prostates have a much lower risk. So here's another bipolar versus bipolar TERP. This was a systematic review and meta-analysis, including 14 studies, and bipolar tend to have larger amounts of resected tissue, shorter catheterization times, lower IPSS, and higher QMAX, whereas a bipolar TERP had a higher need for reintervention. And when it comes to my population, what I'll quote patients is really reflective of what the HOLEP data shows. if you look at the largest study, 18-year follow-up out of Canada, really the BPH retreatment rates are on the order of 1%, even at 18 years. So really good long-term durability from a BPH standpoint. So what we're going to see here, here's a patient with a large median lobe. We see these two grooves, the 5 and 7 o'clock groove, and we're going to start within the groove because that's kind of the shortest distance to get to the bladder neck. And once we start to see bladder neck fibers, you can kind of see a transition in the appearance of the tissue here. And then we start marching downward toward the floor of the prostate that will lead us ultimately to the viro. And you start to see glimpses of the capsule here. You kind of see these parallel running blood vessels. Now we're going to do a distal mark, but those parallel running blood vessels are kind of the hallmark of the capsule. Once I see that, I can bluntly then push the adenoma off of the capsule and you see it split. Now the difference with the hole-up, you're using energy the whole time. Here I have to be real careful. And like Dr. Sandhu mentioned, we're really going to take our time to get hemostasis as we go. I think this band electrode does a really nice job. Now we're going to turn to the other side. We're going to do our 7 o'clock groove. Same, I want to get right to the bladder neck as quickly as possible. So I find the shortest distance from the adenoma to the bladder neck, and then we're going to drop down that wall. And I believe this is real time. I don't think I sped this up. So you can pretty quickly get this done. I'm going to kind of incise that mucosa from the 5 to 7 o'clock groove, and that adenoma will quickly be pushed off. Now, of course, I could complete the enucleation here, which is what we're going to do in this case, rather than leaving it. I have a morcellator now, so I can morcellate this tissue rather rapidly. And you still can resect it if you want to, but I think the morcellation saves a significant amount of time, especially for these bigger prostates. Now, in this case, we're actually only going to do a median lobe enucleation. We're not going to treat the lateral lobes too much because this patient was pretty interested in preserving ejaculation, but accepted the risk of the median lobe only approach, which has a much lower rate of retrograde ejaculation. And once this is free, we'll go ahead and enucleate it, morcellate it with the morcellator. And what the bipolar enucleation here offers me is I can also come back and I'm going to look at the apex and we're going to see if they need to do any lateral resection. So I didn't want to enucleate the lateral tissue. I wanted to leave some tissue behind for ejaculation purposes, but we're going to do some resection at the apex, which I think is an advantage of this. So you can kind of see those two lateral lobes are touching a bit, and I'm going to core out just a little bit of this tissue, still going to leave some of the lateral adenoma intact again, just as a ejaculation preserving approach here. And you can see I'm kind of still enucleating in a way here, but once we get this resection done, we'll get a little bit more of that apical tissue out. And then once it's done, we'll go in with the morcellator and morcellate the tissue. And I would say one of the reasons I really do like this bipolar enucleation is that if somebody's in the learning curve and you're comfortable with a TURP, that's always the out. So you can always start with the enucleation, and if you get stuck during the learning curve, you can always convert to a resection if you need to and still offer the patient a pretty darn good outcome, especially based on the data. So here we're just going to kind of fine tune and clean up this side, and then we're going to go to the other side. But you can see we create a pretty nice channel here just with that median lobe enucleation. Leaving all that anterior tissue alone here. I'm not going to do too much up there. I think that helps reduce our bladder neck contracture rates. Most of the time with these operations, I just out of habit kind of leave my catheter in for 3 days. We do a lot of these cases on Friday, so it just works out that they keep their catheter till Monday. Most of our patients are taking them out on their own at home on Monday morning, and if there's issues, they can always come back or call in for any assistance. We do offer this on anticoagulation if absolutely necessary, but for the most part, I still prefer my patients hold their anticoagulation. I don't think anybody's actually reported continuing on anticoagulation with the bipolar enucleation as they have with the HOLEP or the green light, but we find it safe. Generally, I'll leave the catheter in longer in those patients, though, up to a week after, and I'll keep them in the hospital for CBI a little bit longer than I would without the anticoagulation on board. this part is definitely sped up. So that's kind of my median lobe only enucleation approach. Chuck, any questions?
A few. That was great. Excellent video.
Thank you.
You talked about kind of a lot of the points, and I don't know how much the workup changes. I know you see a lot of patients kind of coming from out of town. Is there something that you sort of require for booking a case for these guys?
Really, volume is the only thing I'm mandated because there's nothing on the cystoscopy that I won't address. I tell the patients if we don't do a cysto, we might get surprised and see a bladder tumor. That's pretty low risk. We might send a stricture. That's a low risk. If we find it, we'll address it, but nothing else that really is going to worry me as far as the operation goes. So really, the volume is what I care about most.
All right, great. Any patient characteristics where you go away from this, you just say, a TERP or whole up?
I would say the ejaculation concern is really what turns me away from this. Also, there is a period of incontinence that's expected from all these, not expected, but happens after these enucleation procedures. And if somebody is really, really concerned about incontinence postoperatively, even for the 3-month period at 30% risk, then I'm going to probably lean more toward the aquablation, which does a defined apical sparing approach and really minimizes that post-op incontinence risk.
All right, great. So if someone didn't have a previous enucleation training, how many cases do you think you really need before you start to get a good reproducible results with this?
Yeah, tricky question. I think a lot of it depends on the comfort with doing TERPs. And Dr. Sandhu mentioned, I don't think people are necessarily getting great training in TERPs before. In my experience, I've had patients or physicians pick this up as early as 5 cases, and others haven't picked it up after 30 cases. But average, I'd say 10 supervised procedures would be a pretty realistic expectation.
Any technique changes that you make based on prostate size and shape morphologies?
Yeah, if somebody's got a smaller prostate, 30 grams or less, then I'm really doing 90% enucleation and I spare a mucosal strip on the top of the prostate. We've got a study now we're looking at preserving that mucosal strip really does eliminate that risk for bladder neck contractures. And so that's been a nice, simple adjustment we've made, just kind of 3 o'clock, 9 o'clock, 6 o'clock, enucleate everything in between, leaving a 12 o'clock strip alone. And patients do well, good outcomes still without the risk of bladder neck contractures.
Yeah, great. Makes sense.
Mhm.
You talked a little bit about procedural longevity. Maybe we'll skip over that one. But
Yeah.
if you had a patient, how would you define a failure for a patient that you did a bipolar enucleation on?
Yeah, recurrent symptoms with evidence of obstruction. So either bladder neck contracture or recurrent adenoma. And even, we are peeling the adenoma off of the capsule, but one little cell sometimes can grow drastically and cause these nodules inappropriate, like just the most possible worst growth position it could possibly be to block it up, even though it's not a big nodule, they can still get regrowth. And really quoting the rates again, I think 1% at 20 years is likely realistic.
We talked a little bit about failures with Dr. Sandhu, but how often do you end up using urodynamics on a guy that failed any previous BPH procedure?
I do not. Nope, I don't think that the urodynamics, even in patients we have urodynamics on, we still get good outcomes with the enucleation in most men, and some we don't. But it doesn't seem to. I haven't been convinced that there's any good studies that show urodynamics is predictive of failure of with enucleation procedures.
Okay. If they have failed a previous BPH treatment, do you use it more frequently then, or is it still a pretty rare event for you?
Pretty rare event. I think a lot of times patients are going to come to us with proof of atonic bladders in those situations, but I still offer the enucleation.
All right, great. All right, so that wraps up that portion, but we do have a little time for some case-based discussions if everyone can come back on. All right, so we'll talk about a few cases, one pretty bread and butter. We'll start with here. So you have a very typical guy. You'll probably see 3 of these guys tomorrow when you go to clinic. 72-year-old man on tamsulosin, worsening LUTS over the last year. Prostate volume is 100. He's got a large median lobe. He would like to talk about procedure options. What do you offer to him and why? Nick, do you want to start just because you finished right there?
Yeah, so this is a gentleman. We first ask questions about ejaculation preservation interest. If he's adamant about ejaculation preservation, then I'm probably going to point this gentleman to prostate artery embolization. I don't think that the UroLift works great with large median lobes or large prostates. And then I would also talk to him about median lobe only, but there's still about a 20% risk, even with the ejaculation preserving enucleations, that they'll get retrograde ejaculation. Otherwise, 72-year-old man, large lobe, I'd really kind of focus in on the enucleation surgery here.
Great, Nicole. You happen to be next on my screen. Why don't you give us your thoughts next?
Yeah, in my hands, he'll get holmium laser enucleation. Actually, I trained in holmium, but I also like that energy best. I think it opens the plane really well, and it's very hemostatic, especially when you use the Moses pulse modulation, which has been shown to allow for same-day discharges and same-day catheter removal. So I think that's going to give him a very long, durable result.
Thulium hasn't won you over,
No, not yet.
despite their best efforts. Okay. Jaspreet, where are you going with this one?
So, I'd ask him about his ejaculation, preference. So if he wants to preserve ejaculation, the next question is, are you on blood thinners? If they're not on blood thinners, then I'd offer him an aqua or robotic water jet therapy. If they are on blood thinners, then obviously things like enucleation would work. But again, if they're worried about retrograde ejaculation, you want to be careful. So, our guidelines, as you know, prostate volume is step one, but step two is whether or not they prefer, or what they prefer as far as their ejaculation status goes. And there are some men who are adamant about preserving ejaculation. I didn't think they existed until robotic water jet came along, and then now it's actually much more common. And partly because of that, one of my questions that I often ask is, are you on blood thinning medicines? Because that's extremely important. Robotic water jets, despite our best efforts for anywhere from 6 to 12 minutes or whatever, you have uncontrolled bleeding. And you can do the best robotic water jet, and there's some men who'll get a 3-gram drop in hemoglobin. We've had to transfuse at least 1 or 2% of our patients after robotic water jet therapy. So I'm very, very cautious in patients who are on anticoagulation or antiplatelet agents when it comes to robotic water jet. But those are essentially the type of things I ask.
I feel like more and more I'm asking guys to, why are you on anticoagulation?
Yeah.
It's like, oh, AFib, okay, great. I know that's not much. Mitral valve, oh, forget it. I'm never getting you off that. Like,
Yep.
Paul, what would you do with this case?
Well, it depends a little bit on which hospital I'm at, but not every hospital I'm at has access to a high-powered laser, or we don't have aquablation in Australia at the moment. So TURP is still a good operation for this man. It's a larger gland, but if it's mainly median lobe, you can resect that very quickly. And the other thing that I might suggest too, I think putting these men on a course of 5-alpha reductase inhibitor for 6 weeks often shrinks the prostate down a little bit, helps deal with the bleeding, and means that you can take on a bigger gland with a TURP if that's the technology you have access to and you're comfortable doing one of this size.
The bleeding stuff has really been up and down in studies. You feel like in your experience, you really notice a difference?
Yeah, look, I think there are studies that do support it, and certainly anecdotally, I think 6 weeks on a 5-ARI, it does seem to make a difference for these patients. They do seem to bleed less, so that's what I do in my practice.
Yeah, and that's about usually the time from clinic to OR too,
Yeah, that's right.
So,
That's right. And I mean, not everyone wants to tolerate it, but I think it's at least worth discussing with the patient. I don't think there's much to lose.
yeah, no, that's a great idea. All right, so case number 2, very different patient type. So 45-year-old man on daily Cialis. He is very ejaculocentric, to steal a term. He's also concerned about maintaining his fertility and has avoided alpha blockers due to the concerns about ejaculate dysfunction. His LUTS are getting worse. He's interested in procedural options. His prostate volume is 45 cc's. He doesn't have a median lobe, but that's all you know thus far. So what additional testing are you going to get on him, Nick?
So, I somehow know he doesn't have a median lobe, which is important. Obviously, a cystoscopy would be meaningful for a 45-year-old. Something doesn't quite add up there, but it could just be tight prostate. IPSS, Uroflow, PVR, urinalysis, just to make sure there's no infection. That would be my workup. And then when it comes to options, I would lean toward either the implanted device, prostatic urethral lift. Probably for this patient, I'd lean towards the iTind more than the prostatic urethral lift.
All right, great. Nicole, what would you offer this young man?
Yeah, I mean, I think this is exactly the type of guy we were talking about before who clearly has a bladder neck component to this. So that's what you need to be looking for. I think office cystoscopy is actually helpful if you can get him through it. Not every 45-year-old is so ready to have an office cysto, but I think if you can get him through the office cysto, and I think it's underappreciated, actually, the bladder neck elevation on cystoscopy. You really have to look for it. But if you get up over the bladder neck and have to really look down to find the trigone, then you know you have it. But I think this is exactly the type of case that an I-10 would work great for, and it doesn't burn any bridges for future therapy. I think he would do well.
Yes, Peter Paul, you think there's a role for pelvic floor physical therapy for this guy? We try to put some new behavioral stuff in the guidelines.
I don't think so. I mean, this is a patient that I would start on alfuzosin first, right? I mean, start alfuzosin, even if he's concerned about alpha blockers. If he's got a primary bladder neck obstruction, should help him, right? Alpha blockers seem to work relatively well for that. But then otherwise, I mean, offer him whatever you want. Now, Nicole said, these men don't tolerate cystoscopy very well. I agree. And I doubt very seriously it tolerated TIPD very well either, which is much worse than a cystoscopy in the office. So, you have to talk to these guys. Like a Resume or a waterway prothermal therapy or a prostate urethral lift, I think are fine. And those would probably be good options for this gentleman.
Paul, anything you would offer him that we haven't
Yeah, I
already
agree with
discussed?
Jesprit. There's not much to lose by trying alfuzosin. If he doesn't like it, he can always stop it, and things will go back to normal.
Yep.
And I think water vapor thermal therapy, he'd be suitable for that. And there's you certainly be confident he could preserve his ejaculations if he does need surgical therapy.
All
That
right.
would be my preference.
We may have time to address a few chat questions at the end if people want to populate our chat with a few options here. We do have one more case. 6-year-old man who has a large bladder diverticulum. He's naive to urology. He's not on any meds. He did have a UTI a few years ago. He was on antibiotics. He got better. You somehow know his prostate volume, even though he's never seen a urologist, and he has no median lobe. His PSA is 2.5. His IPSS is 18. Nicole, how do you counsel him about medications? Do you say, hey, we got to start you on something, or do you sort of talk about procedural options?
Yeah, I think, his IPSS is significant, 18. I guess I would want to know, yes, he has the bladder diverticulum. Yes, that will impact the accuracy or reliability of residual urine check, because you're going to often get the bladder diverticulum volume. But I think you need to know more, like how well is he emptying his bladder? What is he bothered by? Is it mostly storage symptoms, or is it mostly obstructive symptoms? And I think if you're pretty certain that there are obstructive symptoms here with this prostate of 60 cc's, I don't think it's wrong to start medical therapy. I do think, though, that you need to think about the bladder diverticulum as potentially being a consequence of the bladder outlet obstruction. In those cases, I think you're often better off with something that resects tissue and opens the channel better.
So the MTOPS data should tell us this guy should be on an alpha blocker and a 5-ARI when he leaves your office. I don't know if I've ever talked to anybody into starting two medications at their initial visit, but do you guys try to get these guys to start two meds?
Well, I mean, it all depends, right? I mean, if this patient had a worse quality of life score, 3 is mixed. So I literally saw 4 of these men today, but they were 80. They don't want to do anything. So these patients, it depends on what they want to do. You offer them all the different treatments, and often they choose not to do anything. Like, I'm comfortable. A 60-year-old man might not want to risk, ejaculatory dysfunction. So yeah, I mean, some of these men who come in with a really bad quality of life score, say it's 4 or 5 or even 6, and they've never had any medicines, they've got a large prostate, somehow, you start them on 5-ARIs and alpha blockers. And typically I tell them you'll have an immediate effect with the alpha blocker, and the 5-ARIs take a while, but that's pretty much it. There's a question in the chat about would you try another alpha blocker if it doesn't work. Alpha blockers have essentially the same symptom relief. The reason for choosing different alpha blockers is their side effect profile.
Great. So I think when these guys with the large bladder diverticuli, I'm always sort of unsure of when I need to go after that. Does anybody have any tips or tricks, things learned over the years about, man, I wish I would have taken care of his bladder diverticulum when I did his outlet?
Uh, I find that every time I don't take it out, I end up taking it out later. And similarly, if I ever do a diverticulectomy without addressing the BPH, I always end up doing the BPH surgery later. So I'm pretty aggressive about tackling both. If we're going for one, I tend to go after both.
I would have just the opposite experience in 20 years. I very rarely take out the diverticulum. I think the ones that you should be concerned about are the ones that have the really narrow neck, and particularly in a patient with like recurrent UTIs or something where you think it's being, an issue.
And sorry, go ahead, Paul.
I would agree with Nicole. I think I probably would ignore the diverticulum and assess them in terms of their flow rate, symptom score, and treat them regardless. And then you see what happens, and maybe address the diverticulum if that doesn't solve it. But often it doesn't make much difference.
Well, going a little old school, nowadays we do a lot of robotic simples. If you're doing a robotic simple, doing a robotic diverticulectomy makes sense. So often if we're doing a robotic simple, and a man with a larger volume prostate, obviously, and they've got a diverticulum, we tend to take care of both of them.
All right, great. Thank you so much to all of our panelists. I want to save a few minutes to do the post-test questions. I think we addressed most everything else in the chat, though, okay? I want to take the last minute. You need to point out some of the related educational resources provided by the AUA. You can see the place to see the full guideline here. Please note that this does require access to log in. If you do not have one, you can create a login for free. AUA has a podcast on BPH guidelines as well as patient education materials that can be found at the Urology Cares Foundation. Links to these resources can be found on the Innovations content tab on AUA University, and you can see them there. I encourage you to check out these excellent resources. This concludes our program today. Thank you so much. I hope you have a wonderful rest of your day, evening, or wherever you are.